I'm going to talk about treatment recommendations. For this, I've mainly based it on the latest ones presented by EULAR in 2023, and I'll also include some input from the GRAPPA group from 2021. I won't mention the American ones because they're from 2018, so let's start with the European ones, which include 7 general principles. Since psoriatic arthritis is a multidisciplinary and heterogeneous disease, being a heterogeneous disease, it requires a multidisciplinary treatment approach. When choosing the treatment, we must take into account efficacy, safety, patient preferences, and costs. They consider that the rheumatologist should be the conductor of the orchestra in managing this disease, primarily responsible for handling the musculoskeletal manifestations in our patients. What should the goal be? Well, to improve health-related quality of life by controlling symptoms, comorbidities, and through appropriate treatment selection. To achieve this, we must consider all musculoskeletal and extraskeletal manifestations, as well as the comorbidities that my colleague has already mentioned. Both this, as well as efficacy, safety, and the role of the rheumatologist are subtle nuances compared to the previous points. And there is a new principle that states we must take into account the mode of action of the therapies we intend to initiate when evaluating the benefit-risk-benefit for our patients. These recommendations focus heavily on musculoskeletal manifestations, whereas those from GRAPPA address other domains more extensively. An important difference. GRAPPA also includes general principles, such as that treatment should be a shared decision with the patient, that clinical remission or low disease activity should be achieved, and that clinical management involves a complete medical history, physical examination, as has been well mentioned, patient-reported measures, laboratory tests, and imaging studies. What stood out to me as important is that GRAPPA discusses the use of biosimilars and also treatment optimization. They state that in order to use a biosimilar, it must have been approved through an appropriate review process with regular evaluations, and there must be pharmacovigilance for these patients. In addition, it is very important to consider the potential immunogenicity they may cause. The extrapolation of biosimilars that have been studied in other conditions to psoriatic arthritis is accepted. In principle, the decision should involve both the clinician and the patient, and the savings generated by biosimilars should be used to make these drugs accessible to a larger population. As for optimization, it is recommended for patients who have achieved clinical remission. And again, the patient must be involved. We need to inform them about the potential downsides of this optimization, or even of discontinuing the treatment. So, in patients who have achieved clinical remission, the medication is gradually reduced, and there comes a point when the disease may return. And in these patients, restarting the treatment may not lead to remission again. Or it may be that we begin to taper down and remission is not maintained. And we also don't know what might happen with these patients' comorbidities if we are not treating them properly. So let's begin with the recommendations. I've made tables, lots of tables, in which I will indicate the level of evidence, the grade of recommendation, and the changes compared to the previous guidelines. So, the main objective is remission or low disease activity through regular evaluations and adjusting the treatment according to the patient's current condition. The initial treatment for musculoskeletal manifestations should be oral non-steroidal anti-inflammatory drugs, and when appropriate, local glucocorticoid injections. Here, a nuance compared to the previous guidelines is that they included oral glucocorticoids, but these no longer do. Alright, so let's begin with peripheral arthritis. In principle, starting methotrexate as a conventional DMARD would be indicated. If the joint involvement is polyarticular, or if it is mono-oligoarticular with poor prognostic risk factors, such as existing radiographic damage, nail involvement, elevated inflammatory markers, and skin involvement. If at least one conventional drug fails, then it would indeed be appropriate to start a biologic drug, although the specific biologic is not specified, whereas the GRAPPA guidelines go into a bit more detail. In the selection of the biologic drug, in fact, they position anti-TNFs ahead of conventional drugs, and they do list anti-TNFs, anti-IL-17, IL-23 inhibitors, and TYK2 inhibitors ahead. For example, of IL-12/23 inhibitors and apremilast. Another nuance concerns the use of JAK inhibitors. They recommend them if at least one biologic drug has failed or if that biologic drug is not appropriate for our patient. This is the new development. And they mention apremilast if the articular form is mild, if there is failure of a biologic drug, or if the biologic drug or the JAK inhibitor is not appropriate for our patient. Regarding other musculoskeletal manifestations, such as enthesitis, there is no change compared to previous guidelines. We know that the guidelines recommend starting a biologic drug if non-steroidal anti-inflammatory drugs or local glucocorticoid injections fail, without going through conventional drugs. Regarding axial involvement in psoriatic arthritis, it's similar. Treatment is first attempted with non-steroidal anti-inflammatory drugs, and if these fail, we would then need to move on to a biologic drug, an anti-TNF, an anti-interleukin-17A, an anti-interleukin-17AF, or a JAK inhibitor. And the update here is that JAK inhibitors are now placed on the same level as biologic drugs. As for dactylitis, GRAPPA is getting a bit more involved. And it mentions a strong recommendation for anti-TNFs, anti-interleukin-17s, JAK inhibitors, and apremilast, and a conditional recommendation for non-steroidal anti-inflammatory drugs. For glucocorticoid injections, methotrexate, which wasn't included in previous guidelines, and abatacept because they haven't shown as much efficacy in clinical trials. Another update compared to previous versions is the section they include on the treatment of patients with psoriatic arthritis who have extensive skin involvement, uveitis, or inflammatory bowel disease. They also mention that if our patients with skin involvement have not previously been evaluated by a dermatologist, we should refer them. So for skin involvement, it would be appropriate to opt for IL-17 and IL-23 inhibitors, whether it's anti-IL-17A, anti-IL-23, or anti-IL-12/23. In patients who, in addition to psoriatic arthritis, also present with uveitis, the recommended biologic drugs are anti-TNF agents, but not etanercept, because it has even been shown to potentially worsen the symptoms. And in patients with inflammatory bowel disease, we should note that anti-IL-17 worsened the condition. So we can use anti-TNF, anti-IL-23, anti-IL-12/23, or JAK inhibitors. Regarding nail involvement, this comes from the GRAPPA guidelines, since EULA didn't mention it much either. And so practically any anti-TNF biologic can also be used. Anti-IL-17, anti-IL-23, and IL-12/23. What happens? Because it's great when the patient comes in, we give them the first drug, but what happens if it doesn't work? Well, they recommend switching to another biologic drug within the same class or a different class, or even directly to a JAK inhibitor. This is also an update because previously it wasn't positioned as the first option for switching, and they also briefly mention reducing treatment optimization if clinical remission is achieved. Okay, so as I mentioned at the beginning, it's quite important to individualize treatment, especially for those patients for whom it may not be appropriate. What comorbidities, aside from the ones Joaquin mentioned, do we have to consider? Well, for patients with high cardiovascular risk, we need to be cautious with the use of non-steroidal anti-inflammatory drugs and with the use of JAK inhibitors. In patients with congestive heart failure, we should be cautious with glucocorticoids and avoid anti-TNF agents. In patients with a history of deep vein thrombosis, we need to be cautious with JAK inhibitors. Methotrexate should be used with caution in patients with obesity, and it should be avoided in patients with fatty liver or with hepatitis B or C. And we need to be cautious with all biologics, apremilast, and JAK inhibitors. In patients with hepatitis B and C, HIV, tuberculosis, and recent malignancy. That's why we always request serologies both at the beginning and if we plan to change the treatment. Also important, in patients we see in clinic who have both psoriatic arthritis and multiple sclerosis, anti-TNF agents should be avoided. In fact, in some cases we are using anti-interleukin-17. And in patients with a history of depression, we should avoid, or rather, exercise caution with apremilast. Alright, so we have a patient whom we are now diagnosing with psoriatic arthritis. We've measured the indices, there's disease activity, and we need to treat it. So what's the treatment plan? Just to summarize. Well, if the patient has polyarthritis or mono-oligoarthritis with risk factors as we've seen, the treatment should start with a conventional drug. Methotrexate is the one most recommended by the guidelines, or something similar. Patients with mono-us oligoarthritis without risk factors, patients with enthesitis or axial involvement, we start with non-steroidal anti-inflammatory drugs or local glucocorticoid injections, if appropriate, for instance. How long do we wait for the drug to take effect? Well, with a drug like methotrexate, we should expect some improvement by 3 months after starting treatment, and our goal is clinical remission by 6 months. If that is not achieved, then this is where we will initiate the biological drug. It will then depend on the characteristics, comorbidities, and extraskeletal manifestations. With non-steroidal anti-inflammatory drugs and local injections, we should expect a certain level of improvement within 4 weeks. If that's the case, we should continue it and slightly adjust the anti-inflammatory treatment, and if the goal is still not achieved, then we would move on to using a biological drug. However, if it were mono-oligoarthritis without risk factors, we would go with a conventional drug first. Again, we should monitor these patients with regular follow-ups, expecting improvement within 3 months of starting the medication and reaching the treatment goal by 6 months. If that goal is not achieved, then a switch to either another biological drug or a JAK inhibitor would be necessary.